for analyzing big data. So you're talking about genetics. When you do genome sequencing, you have thousands of mutations that come across. To be able to just narrow it down to the few that you should be studying in clinical trials, AI is a great tool. So it's good to prove or suggest associations, but not to prove the hypothesis. Another area which I'll be talking about is computer vision and surgical AI. So use of AI in the surgical space is again another important aspect. So if you look at all, this is just a kind of a pie diagram of the number of studies done and where applications have been used. The biggest dot is in prostate diagnosis. That's really where within urology AI has been used most. But I think all these boxes are going to expand as time goes on. Just to start off with, kidney. Radiomics is something that we've been using all along. So you have a renal mass, and with the renal mass, you identify the 3D volume of the tumor. You look at the standard things like density, intensity, depending on what imaging modality you use. But you are able to also look at quantifying shape, quantifying globularity. There are multiple readings that come out with it. And then that is what are these radiomic features. You can add things like texture, enhancement pattern, and various kinds of analytics, put it all together in a machine learning algorithm, and it spits out, whatever are the questions you want to answer. And on top of that, if you also add biopsy data, clinical data, the accuracy of these features becomes better, as you see with these heat maps. So that's where, the field in radiomics, Dr. Vinay Dudalwar at USC has really led the way in this. And there are already multiple publications on differentiating malignancy with benign, trying to predict the histological subtypes, trying to predict grade and upstaging. So for example, to T3, one of the projects he's just finished is an automatic quantification of a nephrometry score. So nobody has to look at it. It'll spit out a nephrometry for each renal tumor. That saves time and energy. And so with this is one of the recent publications we had. Again, the accuracy of this, and it's never going to be 100%. It'll give you probabilities. It'll say for this tumor, it has an 80% chance of being cancer. It has a 30% chance of being a PT3 tumor. It has a 40% chance of being a papillary tumor. So then you have to use those probabilities in the individual decision making. So it's never going to be able to say 100% cancer versus benign. For bladder also, it has been used in various formats. I think PDD and enhanced cystoscopy automation, I think, is one area where it will help reduce the learning curve. I think from imaging data, both MRI and CT, there is a lot of interest in predicting invasiveness, response to neoadjuvant chemotherapy as chemotherapy is going on, etc. And so this was one study that came out of China that looked at 441 bladder cancer patients and looked at various aspects of imaging to predict, invasiveness, and they actually found that this model was slightly better than radiology and didn't have much variability. And that's another theme you'll see. It'll reduce inter-observer variability in various imaging-based parameters. Prostate cancer obviously is the one where it has been used the most, part is like improving workflow. So all of us who do MR fusion biopsies, segmenting the prostate is a very tedious process. Now, those are things that AI can do very well. So it'll reduce the burden of workflow very easily. But then when you go to actual diagnostics, can it predict or can it visualize a pyrite lesion? Can it show accurately what that pyrite score is? Can it show whether there is ECE or whether can it predict, in pathology slides, Gleason grading? That's where it becomes a little more important. And as you can see here, the number of publications and papers on AI and prostate cancer, AI and MRI are really going up. And this is actually an area of acute interest. If you look at papers that have looked at segmenting it, so looking at the outline, which is peripheral zone, which is transitional zone, the accuracy is fairly good. It's above an area under the curve of about 8.7 and above. When you look at lesion identification, also it is fairly accurate. In fact, lesion identification and segmentation, the area under the curve is above 0.9, again performing quite well. And then if you do lesion characterization, that is where the variability goes up, and there is a wide spread based on, again, what the input data was. But the overall thing is it's not going to replace, but it is going to help the radiologist in getting better and improving their workflow. The negative predictive values of these are very good, so you can actually triage which scans you should look at first, which scans you can look at later, depending on the likelihood that these scans are positive or negative. And there have been, this is just one representative paper, but multiple papers that show that if you add that computer analysis, and most of the MRI machines now, Philips, etc., GE, automatically have these AI algorithms built in that can help you do various components of lesion identification, mapping, segmentation, etc. So it's not something you have to develop. These are all commercially available. But that's not the exciting part. This is the workflow part. I mean, whether it is able to do it quicker than what a radiologist can do or help the radiologist's day go smoother is good. But I think it'll be more important if we can actually improve the predictive value of MRI, better stratify which patients with a positive MRI or a PIRATS 3 to 5 need a biopsy, and improve the predictive value of that biopsy. So for example, even though there have been a lot of strides made in MRI diagnosis, it still is not completely sensitive. It still does overdiagnose some insignificant cancers, and as we know, 16 to 20% of MRIs are negative in the setting of clinically significant cancer. So there is a lot of room of improvement, and that is where maybe there is a chance that AI could look at parameters that the conventional radiologist cannot look at. And also, as we all know, the MRI readings and PIRADS classification is significantly operator dependent. There is a lot of variability even within the radiologist as well as between radiologists in this. In fact, between radiologists rating, a kappa score is only 0.24, which is fairly low and fairly poor. So for example, if you have an MR image, you have a voxel of radiographic data, which can be looked at by an AI algorithm, a computer vision algorithm that picks up various features, and it makes a vector map of those various features. Similarly, if you look at a whole mount pathology correlate of that same area, you can have various features on the pathologic slide and create a pathologic vector map. AI is able to fuse these together to be able to give you a composite vector of both pathologic as well as biopsy characteristics to better represent the clinical outcomes of these patients. So if you do these things in multiple areas, and if somebody sits there and looks at various characteristics and inputs it, then you can get a series of these patient data. You keep getting tumor, no tumor, what tumor, and then you start training this ground truth and then checking it with a pathologist, and that's your training part. It could be supervised learning to begin with, and then the algorithm itself makes the learning process faster, and then you keep getting these things, and this is what is your AI algorithm can calculate, and then you can create better roadmaps, and the more input you put in, the better are the AI pathways. So this is, and then you can check the accuracy, and as you'll see it, the accuracy is going to keep improving as time goes on. And also there are better and better algorithms to look at and do better computing, the whole green AI and the whole concept of PAI RADs is now coming into place to maybe improve the predictability of risk stratification of prostate cancer. So for example, from an MRI image here, T2 weighted ADC map and diffusion weighted imaging, you can create a green AI heat map. And this is completely automated. Nobody has to do anything here, and you can get a complete composite heat map of the prostate that inputs all information from the MRI. So this is something that is really exciting. And then as you add again models 1, 2, and 3 and keep the learning process going, your area under the curve improves. I know we have a talk setting up. Do we really need a biopsy? Are other things, virtual biopsy is helpful, but this is where it'll come in. It'll get you inputs from MRI, it'll get you inputs from your PSMA imaging and other biomarkers to be able to predict better on cancer. And I think this risk stratification is where AI will help the most. This is a risk stratifier that we created at USC with our radical cystectomy database, again working with our data scientists, that it really outperforms conventional totally clinical based risk stratificators or predictive models that are out there currently. And my final slides is on AI-based surgery. So if you look at data that we looked at in MRI, biopsy, clinical data, those are fairly structured. But when you look at computer videos, what you saw today, it's completely unstructured. So the quality of surgical video, the quality of the video itself, how it is captured, the lighting, the colors, that everything varies between the camera source. And so therefore, to be able to create algorithms that can use surgical data and create models is difficult. Plus, if you are able to add more structured data onto that unstructured component, I think the utility here goes even more. So basically what you do is you collect surgical videos, enough surgical videos, somebody has to manually go in and annotate the various anatomies of interest based on what project you're trying to do, and then the system will look at this anatomy, create algorithms, and then be able to create various applications, whether it is workflow, whether it is education and training, whether it is quality control, and whether it is decision-making support. And on top of this, you can also add other data fields. Like, for example, if you want to predict how long an operation is going to take, you first put your scope in. If you see adhesions, the AI algorithm is able to calculate that this is going to take longer. And if you add clinical data onto it, it's going to be able to predict it even better. So just to give an example, we all know image recognition is very common in day-to-day life, facial ID and all that is there. How do you do it? So when you give a picture of a cat and just label this is a cat and this is a dog, this is a tiger, the system is able to look at features that, okay, they have eyes, but everybody has eyes. So they give a certain weight to that factor. But they have whiskers, they have pointy ears, and then each of these features gets a certain weight. And that's how you identify this as a cat. And the same thing happens with surgical AI. You come in there, you identify anatomy, you identify an outcome that this was bleeding, this was no bleeding, this was positive margin, no positive margin. The system is able to then figure out enough features, give them weights, and then you use neural networks to create it. So where are the applications? The commonest ones commercially available today are the first category. OR scheduling. How should I book cases in a day? You can know that. Turnover, is the room turning over on point. The OR board can be managed. So you're in a case, and if the AI algorithm predicts you should have been at the anastomosis by this point, but you're only in the nerve bundle release, it can calculate automatically. You're running late. The OR manager can know that to reschedule something after you. Now already there are companies that can auto-generate an operative report based on your video. You don't have to dictate, you don't have to type. Then quality, you can look at surgeons whose outcomes are poor and they can actually tell you what is the variability between that and an index surgeon whose performance is standardized. And then do an audit and to see, do you look at the ureter, do you look at the ureteral orifice? These things can be done fairly easily. So just to give you cases, most of these are in lap chole. You can do this phase detection. So this is an algorithm that is automatically knowing that which phase of the lap chole you are in. So it can recognize based on the instrument, based on the structure, that's the phase. Similarly, if there is an event that occurs, there is a bleeding that occurs, that a clip had to be applied, it can actually, on the right side, it can tell you in which step some bleeding occurred, a clip was applied. So it can actually keep an audit trail of all intraoperative events. So this is currently available. Secondly, by the visual field clarity, it can actually tell you objectively what is the amount of blood in the field, and it's a better calculator of the visual field clarity during the case. You can have a blood loss where you lose a liter in 1 minute, you control it, but the rest of the case, the field is clean. Or you can have this generalized oozing that goes on throughout the case, so it can actually tell you what the average clarity was during the case. Similarly, surgical performance. This is a robotic case, just the movements of the instrument. So the green and red are the left and right hand. An expert, the movements are very precise, and in one area, the novice is all over the place. But instead of using the actual data from the controller, here the system is tracking the instrument movement, and it can actually tell you how many times the instrument pass pointed, how much variability there was in the movement. It is all automated and can be done. So even for laparoscopic surgery, this can be done. Here is a real-time indicator. Green means it is safe to clip because I see both ends of the clip nicely. The moment the ends of the clip are not seen, that dot turns red. That means you're not supposed to. Intraoperative guidance can be given. And so all these can be, are areas. Now this is actually a very interesting thing. A friend of mine created on an off-the-shelf computer with 20 videos of cystoscopy, labeling right lobe of the prostate, left lobe of the prostate, bladder neck, verum montanum. And this is real time, the system showing you as he's withdrawing the scope, outlining the right lobe, outlining the left lobe, outlining the veru. It takes very little data, off-the-shelf algorithms to create this. So this is something where it is going to be fairly helpful. And just to kind of look at the limitations, as I mentioned, the data is variable. I think it's a very time-intensive, tedious thing to annotate all these. Remember, 1 second of video or 1 minute of video is 64 frames a second. So you have to really go and do frame by frame. Secondly, who's going to pay for it? There's no financial reimbursement model for these things. Regulatory compliance things, people don't like storing data and video for medical legal things, and no surgeon likes to be audited. What is my performance? Put it out there. And so will the surgeons accept being recorded or such? So to conclude with AI, it is here to stay, whether it is in medicine or all aspects of life. I think the data quality is as important as the quantity, but quantity is important too. I think there are increasing uses of public domain. So the MP, MRI and pathology slides, now there are data sets of these that are publicly available that you can test against genomic because of the TCGA. I think you do need collaboration between your data scientists and software engineers. You can get off-the-shelf platforms to get doing it. You have to be careful not to overinterpret the outcomes of AI because p-values of 0.05 can be easily obtained with large data sets. And I think the best AI algorithms are going to be using not just one domain of data, but looking at clinical data, radiologic, pathologic, molecular, and then surgical data to give the best outcome. So again, thank you for your attention. And
thank you, Mihir. I think this was the first time that I at least have heard a lecture on AI where you've actually related actual applications and which are progressing, such as genomics, such as bladder staging, etc. And it is very, very impressive, very useful for us because this was labeled as a STAR talk, but the previous STAR talks were really STAR talks, and this was reality. Thank you very much.
Thank you, Dr. Mihir, for this wonderful talk, a peep into the future. Thank you, panelists. And now I will call upon the next panel, Dr. Mihir Desai, Dr. Uttam Mete, Dr. Ganesh Bakshi,